So before we get started on the lecture, does anybody have questions about the presentations on Monday? 9 in GH2. You don't need to turn anything into me. You can use notes if you want to. You don't need to use any visual aids, but you can if you want to. Okay? And this is, you're going to be teaching your patient about their diagnosis. Blah, 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 blah. Okay?
Will you give us like a specific situation?
Didn't I?
I mean, kind of. But there's multiple ways that some of these things can happen.
Yeah, like mine's preterm labor.
So like, did you
32
do
or
C-section?
HB.
Okay, well, we can answer those questions after class.
Okay.
You have specific things. Okay, a nursing assessment of the newborn of this person here, the newborn. Okay. So one of the things that we do with our assessments on babies is we do a gestational age assessment. Now we know how many we usually know how many gestational weeks they are when they're born because mom comes in and we say she's 36 weeks and 7 days, or she's 40 weeks, or she's this, that, and the other. And that's based on her last menstrual period and or
Found on the sidewalk.
where is she? Oh, she's not here yet. Yes.
Most remind
Oh, okay, thank you. I got them here. I'll hand those out. I had 3. Did someone get theirs? Oh, God. Oh, that's the third one I dropped. Anyways, all right. Hold on. Okay. So where was I? Anyways, so gestational age. So based on last menstrual period or an early ultrasound. And those things could be wrong. They could be off a little bit. So we can do an actual assessment on baby. And from those assessment criteria, we can estimate their gestational age yet again. This is something that back in the day we used to do on every baby before 12 hours of age, and now we don't hardly ever do them. And if you do them, it really doesn't change your care any at all, but it's just a little bit more information for you if you need it. Now, the one time that you would like to do gestational age assessments is one, if your mom wasn't sure of the dates, if she didn't have any prenatal care and she just came in and pushed a baby out, we have no idea what that baby's gestational age is, or if this baby is preterm or small for gestational age, where you're questioning how old this baby actually is. But again, it really doesn't change your care any at all. So there's 2 different parameters that we look at. We look at a physical characteristics and we look at neurological characteristics. Some of the physical characteristics are the resting posture of the baby. So when the baby's just laying there not doing anything, is the baby laying there with their arms straight out, their legs straight out, or are they all flexed in? Okay. What does their skin look like? Is it dry and cracked, or is it thin and shiny looking? Lanugo. What's lanugo? Hair. Do they have an abundant amount of hair? And usually that is like on their back and shoulder areas. And the one thing that will skew this is like Hispanic babies typically are born with a lot of hair, even if they're term. Okay. The sole of the feet. We look at the soles of the feet and see how wrinkly or how many creases there are. Other characteristics are the breast tissue. We kind of guesstimate the size of the breast bud. So when you palpate the breast tissue, you feel this little bump in there. That's the breast bud. The ear form and the cartilage distribution. So is the pinna of the ear nice and curved, okay, or is it flat? And as far as cartilage, if we if we bend the ear, does it pop back into place or does it stay bent and unfold slowly? And then the genitalia, we look at different characteristics of the genitalia, and we'll cover that when we get to male and female. So this baby is laying there, their arms are straight, this baby's legs are straight. So the more straight they are, the more their score is going to lean towards being preterm. Okay? Here's another example. The legs are a little bit flexed, the arms are slightly flexed, but this is still would be a preterm type score. Here's a baby all flexed up. Okay? So this is a more term looking baby. Now, this may be difficult to see, but on these feet, when we're looking at the soles of the feet, this baby has a few creases and wrinkles, not very much. And so this baby would have a more preterm score. This baby has a little more creases, they're a little deeper, they're a little more defined. So this baby will have a little better score, but even still, we have some smoothness, like we have these deep creases here up on the balls of the foot, but not so much going on in the lower part of the foot. Compared to this one where you can see creases pretty well throughout this foot, this is a more term baby. Now, when we're looking at the breast bud, this is probably hard to see too, but that's a little breast, a little areola. We can squeeze it or we can palpate it and feel that bud underneath, and we just guesstimate, does that feel big or small? And the smaller, the more preterm. And you can actually measure if you wanted to, but oh, there it is. I was trying to find it. It's right up here. It's really hard to see on the slide. But I usually just palpate. Now, as far as the ear, so this ear is well curved pinna, and we would pinch the ear, fold the ear, see how quickly it would rebound back into place. Here's a more term compared to this baby. More defined. When we fold that ear, it will really pop back into place quickly. Here's just showing that we're folding that ear. Now, when we're looking at genitalia, as far as the little boy is concerned, we're actually assessing the rugae on the scrotal sac. Okay, how many wrinkles there are. The fewer wrinkles, the more preterm they are. The more wrinkles, the more term they are. So this is a little bit of an early baby. And this baby has a lot more wrinkles throughout the scrotal sac. So more term baby here. Now, I'm sorry that this looks black, so pretend like it's not, because it's not an issue here. When we're looking at a little girl, we're looking at her labias. Do her external labias cover, does her labia majora cover her labia minora? Okay? This one doesn't. So that means this baby is more preterm. This covers a little more, but still on the preterm side. And this one completely covers. So this is a more term baby. All right? Now, when we look at the neurological or the neuromuscular components, we're looking at square window, and we'll see what that means. Popliteal angle, arm recoil, heel to toe extension, and scarf hold. Okay? So we will see what those are. So this is the square window sign. So we bend a baby's wrist down to their fingers down to their forearms. Okay? The more term a baby is, the more we can flex that or bend that wrist down. So the more of an angle we have with that wrist, the more preterm that baby is. Okay?
Is it stopping when they're resisting, like a reflex, or is it just you can't push it any further.
Yeah, I mean, you're not trying hard, you just go till it resists and then decide kind of how big your angle is, okay? So the smaller the angle you have, the more term baby you have, okay? Here's another example of that hand flexing down. Now, scarf hold is we take the baby's arm, we straighten it out as much as you can, and then you just kind of lay it across the chest. And where that elbow lands tells us if they're preterm or more term. The more the elbow is to the center of the chest, the more preterm they are. So the more you can't pull that arm across their chest, the more term they are. So this would be a more preterm baby. That elbow is almost right in the center of that chest.
So with a, oh, never mind.
So with a more term baby, you pull that arm over and you can't get that chest past that same side nipple, okay? It doesn't go to the center, okay? Here's another example of a more term baby. Well, so let's go back. I don't know where my pictures are. So the popliteal, gosh darn it. The popliteal angle is, where's the popliteal? Behind the knee. Okay? So what we're doing is we are laying the baby on their back. We're taking their legs and we're trying to see how far we can straighten their legs up onto their belly. So we've got their legs up on their belly, their thighs kind of up on their belly, and we're seeing how far we can straighten their knee. Okay? The one thing we don't want to do is we don't want to roll the baby so that the baby's spine bends and skews our popliteal angle. We want to make sure the sacrum stays on the bed. We bring the knees up to the belly and then we try to straighten the leg. That's the popliteal angle. Okay? The straighter you can make those legs, the more preterm your baby is. The more you can't straighten those legs, the more term the baby is. Arm recoil is wherever the baby's arms are at rest, we straighten those arms out. We hold them for a few seconds and then we let go really fast. And the more term the baby is, the quicker those arms are just going to go like back to a flexed position. The more preterm the baby is, they're just going to lay there or come up just a little bit. Okay. Heel to toe extension is very similar to popliteal angle. We keep the baby on their back. We make sure their sacrum stays on the bed. We kind of spread their legs out to the side. We bend their knees up and we try to see how far we can get the heel to the chin. Okay? The further you can get the heel to the chin, the more preterm your baby is. Okay? And so what we'll do right now is, how do I, hold on, minimize. We'll take a look at, wait, here we go. Maybe, let me try something else. Okay, here we go. So this is the sheet where we record our results. Okay. So how does our baby look when our baby's just laying there? You pick a picture that most resembles your baby and you fill in the circle. Here's the square window. How far can we bend that wrist? You kind of try to see which one best matches your baby. Here's the arm recoil, what happens when you let go to the arm. Here's the popliteal angle. So you can see we have baby's legs on their belly and we're trying to straighten their knees. So what angle do you have here at the knees? Which best matches this picture? And so forth and so on. Here is the scarf hole. Where is your baby's elbow? Here's the heel to angle. You can see the baby's legs are out to the side, and we're trying to see how far we can get the heel or toes to the chin, okay? So you mark your circles. Then, each column has a designated score across the top, okay? So for whatever score I had my baby, say it was a 3, I would put 3 out here. Say this was a 3, I would put 3, maybe I've got a 4, maybe got 4, and maybe I got another 4. All those numbers are placed over here, and then we add that total. Okay, we add that total, and we put that amount right here, whatever our total is. Okay, now we go down to the next section. And here's some other parameters that we score. So what does our skin look like? We take these definitions and say which one best matches our baby. We fill in the circles. Our lanugo, we fill in our circles. Our soles of our feet, we look and see which one our baby best fits in. Our breast buds, same thing. Our ear, what does our ear look like? And then on our genitalia section, whichever we have, male or female, we fill in those circles. Each column has their own score. We write the score over here to the side for each criteria. We add up that total. Okay? We put that total in here. We add up these two numbers, and put that total score here, okay? With that total score, we come up here under the total score column, and we look at what number our score is closest to, okay? So maybe we had a score of 34. So it would be closer to this score, 35. Maybe we had a score of 38. It would be closer to this score, 40, okay? So we decide which score in this column is closest to our total, and then we go across from that score, and this column is weeks, okay? So if my baby was 34, her score was 34, which best matches the total score of 35, I would go across, and my estimated gestational age is 38. Okay? So that's how we do the Ballard score. They call him Ballard. They call him Dubowitz gestational age assessment. Okay. Now again, we don't typically do these routinely. You can do these at any time you want, but especially if you had a baby who, come on, move, please. You had a baby that you weren't sure of gestational dates, you would probably do this test, okay? All right. Now, systematical physical assessment, a head-to-toe assessment. So a head-to-toe assessment is basically the same that you would do on an adult. You start at the head and you work your way down. And on a baby, when we look at the head, there's some things about the baby's head that would be a little bit different than a normal adult person or even a pediatric person. So imagine this baby just came through the birth canal. Okay, they came head first through the birth canal. And so we want to check to see how the head did from the birth. Do we have any problems with the baby's head because of the birth? Was there any trauma to the baby's head because of the birth? Now, one of the things, I don't have a picture here, but one of the things is if your baby had that internal spiral electrode, that little thing with the little wire on the end that we put on babies in utero to monitor their heart rate, we want to check that out because that could be a source of infection. We did pierce the skin. We want to check to make sure that that looks good and is healing well. But the other big thing that we are assessing is our head swollen? Do we have something going on under the tissues of our scalp? Okay. Now there's a few different possibilities. We can have a cephalohematoma. What does cephala mean? What does hematoma mean? Okay. And a caput secundum. Okay. Caput secundum basically is just edema, fluid. Okay. So how do you tell the difference between a hematoma and a caput? Okay. So a hematoma is a collection of blood, and a caput is just fluid. Okay. The causes are listed there. So we cause some, for the hematoma, we cause some trauma to the tissues or the vessels, and they bled. On the caput, it's just that head continually bashing against the birth canal and just creating edema, okay, fluid. So we've our interstitial fluid is collecting there. The important things here, though, is the hematoma does not cross suture lines. So if you remember that the baby's head, we've got our cranial bones that are not fused. So we've got these places where these cranial plates come in, side by side each other, and that space in between these plates are called sutures. So if we have a hematoma that is developing on this side of the head or the skull, that hematoma will stop right there at that suture line. Okay, so we'll have this really funny looking thing right here on this suture line. Okay, the caput or this fluid swelling edema can cross the suture line, so this whole thing might be swollen. Okay, so the hematoma, you can see that on the first day. The caput, it starts to develop and grow. Okay, so you've created a bruise or you've damaged some vessels, and as those vessels leak over a period of time, you'll start seeing that swelling occur. The caput, you can see that even the second the baby's born, okay, because the head is in there, that edema is occurring in there. So when babies are born, you see this big old caput, okay. The hematoma sometimes takes a little while to absorb and go away. Just like you got a bruise, that bruise could last for 10 to 14 days, depending, okay? The caput, however, yes?
Does it make a discoloration?
Yes. Yeah. So if you can see the skin, it would look purpley or red. The caput, it could look red because it's inflamed, but it wouldn't have that purpley color to it. And the caput will be absorbed probably within 24 hours. As a matter of fact, you can tell the parents when they look at their baby like, oh my goodness, your poor head. And you can say, oh, well, tomorrow you won't even see that, okay? It will get absorbed very quickly. All right, so here is a picture of caput. This is just the fluid. And we have this suture line right here, and that caput, that fluid, is crossing over that suture line, okay? And then this is a terrible picture because you can't even see it. I can't even see it, but this baby has caput, okay? But this next one is very distinguishable. So, like Caput, sometimes when you look at Caput, like, it's not very distinguishable, especially if it crosses over this whole suture line, and this whole part of the head has a little bit of edema on it. Very hard sometimes to see, but this is very easy to see. You've got this weird lump growing weirdly out the head, and it does look like this, okay? Here is this little hematoma. I'm going to go back. So it does not cross the suture line. Right here's the suture, and it does not cross the suture line, okay?
Does it discolor the skin at all? Like, does the skin over it get reddish?
Yeah, it could be red or purple, but you may or may not be able to see it as well because of how much hair they have on there. All right?
Is it firm feeling or more like squishy?
Well, it just depends on how much blood is collected there. So if there's a lot of blood in that little space and it kind of fills it up, it could be a little harder.
Okay.
The caput is just squishy like edema. Okay. All right. So so that's really all I put here on physical assessment because those items were a little bit different. We're always going to look at, eyes, ears, and nose. Make sure there's no drainage. We always, after a baby's born, we will put our finger in the baby's mouth to assess that we've got a full intact palate. Okay, because even if you don't see a cleft lip, you might have some form of cleft palate, and you may have a little tiny cleft lip, but you want to see if your palate's affected. And then that's also another way to assess your baby's suck reflex. If you put your finger in a baby's mouth, they should start sucking, okay, or mouthing it or something. If they don't, then we have a neurological problem, okay? And then you listen to lungs, you listen to heart, you check out the skin, you listen to the belly, you do your capillary refill on babies, and then we have some other things that we're going to look at on babies. And one of those things are reflexes, normal reflexes that babies should exhibit. So tonic neck reflex is when the baby is, so when the baby's laying on their back and their head is turned in to one side, the extremity on that same side should straighten. So if baby's head's turned this way, that should straighten. If baby's head's turned this way, that should straighten. That's called a tonic neck reflex. And then the palmar grasp reflex. So this is the reason why we don't do hand prints on babies, because the very second something touches that palm, that baby should grasp it. Okay? Palmar grasp reflex. Moro reflex is basically the startle reflex. So if you have a baby and you're holding a baby and you lay that baby on a table, you're going to see Moro reflex, because they're going to be like, oh my God, why is there space around me? Okay? Or if you take the blankets off the baby and now the baby's got space, they're like, oh my God, what's going on? You'll see this startle reflex, which is a Moro reflex. Okay? You don't have to go up and say boo. You can just lay the baby down on the table. Rooting reflex is, so if something touches the corner of their mouth or their lip or even their chin, they will go after it like a little bird with their mouth open to try to grab it. That's a rooting reflex. Okay? And then the suck reflex, of course, is you put your finger in the baby's mouth and that baby should start mouthing your finger or start sucking. The stepping reflex is if you hold a baby up, then they'll pull a foot up and down like they were going to take a step. That's the stepping reflex. Sucking reflex, okay? So we check all those reflexes on our baby, okay? And we check them every shift, okay? Once they have that reflex, they should always have that reflex. But if something crazy happened during that 12 hours and you reassess this and that reflex is gone, we have an issue, okay? Now, When we're looking at skin, there's some significant things on babies that we may see that could be normal. Acrocyanosis. So that's when babies' hands and feet are blue or purple colored. This lasts for about 24 to 48 hours. What's happening is baby is shunting their blood to their internal organs. That's the most important thing right now. Babies are trying to adjust to extrauterine life. Okay, so pumping their blood on their own to all their places, breathing, maintaining their temp. These are all new things baby is doing on their own. So with acrocyanosis, babies are kind of just like, let me just feed my internal organs right now and get used to that, and then I'll start feeding everything else. Not that the hands and feet are getting no blood, okay? They're just getting very little, okay? Modeling. It's a lacy pattern of dilated blood. You can see it in parts of their body. You can see it on people, adults, like if someone gets really cold, okay, you could see they might be a little mottled or have a lacy pattern to their skin. Harlequin sign is one side. If you was to take baby from head to sacrum and draw a line, one side would be obviously red, the other side would be obviously pale, okay? Harlequin sign. Erythema toxicum is what we call newborn rash. So those are the little tiny, they look like little pimply things. It could be on their legs, it could be on their face, little whitish, yellowish papules that look like little pimples, okay? That's newborn rash. That is a normal finding, and then within, a week or so, those should clear up, okay? Milia is, if you've seen a newborn baby and the nose, you can see little white pores on their nose. That's called milia. Those are the sebaceous glands. And then vernix caseosus is the white cheesy stuff that babies are born with, okay? So the more preterm the babies are, the more vernix you're going to see over their entire body, okay? The more term they are, that vernix gets absorbed in utero, and then they're born and have very little. But even on term babies, you can see it in the creases of their pits or in the creases of their groins or behind their knees, things like that. And it's a really kind of sort of a sticky substance. And so as nurses, we want to make sure nurses and or patients aren't taking a scrub rag and trying to scrub that garbage off, okay? That is good quality lubricant for the baby, and it'll eventually wash off, so don't be scrubbing that like it's, yes.
In the book it was saying that, like, if you are the delivery nurse, you should notice how, if there is any of that, how it is on the body and where there's more or not. How is that?
Well, it's just going to tell us the termness of the baby. So those babies are covered with it, okay? And if the baby is born really preterm, it will be all over the baby, on the face. It will be everywhere, okay?
So it's not like you should have more in one face or
Oh, no.
Okay.
No. It just is telling us, what we think about the termness of this baby. And when these babies are born, like, we do want to wipe that stuff off because this is slippery stuff, and you're trying to hold this baby and you've got all this goo. We do, try to wipe it all off. Plus, this is another way that babies get cold, right? That's wet stuff. So we want to try to get as much of it dried off as we can. All right, now there's some other marks on the baby's skin. These are birthmarks. Telangiectatic, nevi, or stork bites. So you've seen like little red patches on a baby's neck, or maybe they're on the eyelid or the bridge of the nose, okay? Those are stork bites. Those usually fade unless you're a ginger and they last all your life. Mongolian spot is, I don't know what that word is, but it should be bluish or black, maybe. It's a pigment discoloration, usually on the sacrum, maybe even the buttocks, maybe even in the lumbar spine. You can even see it on the back of the thighs in some cases. This is just a little pigment thing that you see on babies with some sort of dark ethnic background, okay? You can really see these if you have an ethnic parent and a Caucasian parent, okay? These babies, you can see it really good on these babies. Now, this does eventually fade in a few years. It means nothing, okay? It's not significant in any way, but we would want to point this out to parents because parents don't know, and they look at the baby and there's this purpley looking area that looks like kind of like a bruise. So we need to make sure the parents know this is not a bruise, this is a normal sign because your baby is Hispanic or whatever, Italian, or whatever, or African American. Okay, nevus flammosus, flammeus, port wine stain is what I call it. It's just a little collection of capillaries right below the epidermis. It makes just like a little red spot, a flat. You don't feel it. It's not raised. It's just a little red spot. You know, sometimes the size of a dime, a little smaller, a little bigger. They don't grow. They don't, get like a big moly looking thing. You usually see them on the face, somewhere around the temple region. They could be a sign of a neurological disorder, so we do want to point these out. Or it just could be nothing. And then similar is the nevus vasculosus strawberry mark. So these are capillaries right under the skin that get enlarged. And these actually they can raise. They can be, you can feel them up above the skin. These can actually grow to like big, huge, bright red looking moles on steroids. These can get quite big. And then they will usually they eventually dissipate, they shrink down, and sometimes go away completely. Sometimes there's just a little mark there, like a flat freckle or something. But it takes quite a while. It could take up to 6 months or a year if they're actually going to go away. It doesn't really mean anything significant as far as baby's health is concerned. All right, so in an attempt to show you what acrocyanosis is, this is a very pink baby with bluish colored hands and feet, if you could see it, or pale. They could just be pale, or they could be significantly discolored. That's acrocyanosis. It's perfectly fine. There's nothing wrong with baby. Here's the modeling. Can you see that little lacy pattern? Okay. Here's the harlequin sign.
So weird.
Yeah. Sometimes we've seen this horizontally. Usually it's with when we've resuscitated a baby. We've had a really bad baby that we've done, we bag masked and done chest compressions. When we finally get that baby back, like we'll see like baby's really pink or red down to the thorax and the rest of their body is kind of pale. Well, that baby has just shunted all their blood to their central system, and everything down here is unimportant for life. So sometimes we see it that way. Here is your newborn rash, or erythema toxicum. So they just look like little pimples. They can be on the legs, they can be on the face, they can be on the torso. We want to make sure parents know, don't pick at these, okay? Don't put ointment on these, don't do anything to these, just let them do their business. They're gonna come, they're gonna come to the surface, and then they're gonna dissipate, okay? Here's the milia, and tell them, don't be picking at these either, okay? This is normal, it will fade. Here's the stork bites, okay? On the, between the eyebrows and on the eyelid there. There's the Mongolian spot. Can you see it? Yeah. So there's one here, there's one here. Looks like there's even, I don't know if this is shading or anything, but you know, it could be right here on the lumbar spine, it could be down on the butt cheeks, it could even be on the backs of the thighs.
Can it be kind of everywhere?
Huh?
Can it be kind of everywhere too? I mean,
Well,
like-
typically, I've never seen it like anywhere else except on the back, yes.
One thing you're supposed to look for is tufts of hair, kind of at the sacral area. Is that
Right,
what
so
you're talking about, or is that just a hairy baby?
this is just a hairy baby. So this is lanugo over this baby's back. So that's where you see the lanugo the most, is on the back or the shoulders. But your Hispanic babies tend to have more hair, and they might be term. So the more hair a baby has, or the more lanugo a baby has, the more preterm you think they are. But their ethnicity may skew that assessment parameter. But when we talk about a tuft of hair or dimpling, we're talking about in this region right here. So when we're looking for neurotube, so when we're assessing our baby's spine, that's part of our physical assessment. We assess the straightness, and then we check here to see if there's any dimpling, tuft of hair, or a big gaping hole, or a big sac protruding, okay? So we check that out.
I did it at one of my clinicals, we had an Asian baby and it had Mongolian spots up on its shoulder.
Oh, did it?
blades. Yeah. It was different, but they were definitely,
Cool.
yeah.
So here's your little port wine stain. It's kind of there in the temple region. And I don't have, well, here's your strawberry mark. So this is like a really big one. So this could grow on this little baby's face. Now, I said that these usually fade and shrink. And sometimes, and most of the time they do, sometimes they don't. So if this continued and it grew like this big old luff thing, you know, the parents could possibly want her to have that cosmetic surgery to have that removed. All right. Anybody want a quick break before we move on to the next chapter? Last chapter. Stop doing that.
Question on the Mongolian spots.
Yeah.
And I know that if the child has the cafe spots more than 2 or 3, you can say that there's a potential issue.
Yeah.
The only reason I said is because my son has got those.
Oh, really?
And then I didn't know if it was similar with the Mongolian spots. If they had.
No, there's no pathology connected with Mongolian spots at all.
Okay.
You're my advisor. Do I give this in here, you? It's a vaccination, flu vaccine.
Oh, give it to me so that I can hand it in and I
You
can
want me to
check
put it
mark
in
you.
your box?
No, I can keep it right here. I got it.
She'd probably.
Rachel.
She'd probably like.
Rachel.
That's not Rachel.
No, she.
I think that'll be fine.
Was Rachel sitting beside you?
Yeah.
Well, Clay, what would like do?
Yeah. No, I
Do
think,
yours on the Word.
I did mine on Word as well. I figured out how to put the arrows
Took a
in.
little while.
Yeah, it took,
Messing around.
yeah,
Doing stuff around, making fonts small.
getting the pictures in is what was like a pain. It was like I put a picture in and everything was blue and I'm like, oh god.
I thought it was good on my computer, like did my notes, and it was like my boxes were like huge, and it just looked like
Yeah.
the children's
Yeah.
like basic, very basic. Like I need more.
I changed some font colors after I printed it and I'm like, like yellow.
Well, you don't have to print it.
I know.
Okay.
I printed it and brought it today in case she sent me. And
Yeah.
was like, "How about today?"
Because I put color and stuff in there, but obviously I didn't print it, but
Yeah.
I just kind of color coded,
Yeah, that's what I
like,
did too.
you know, your diagnostics and treatments, and just so they're maybe.
Yeah.
from the center.
Well,
But I didn't put a color chart. I probably should have like put a color code down.
Well, I did like diagnosis in red,
Yeah.
you know, like, I had it totally different, like completely different from what it is now. At first, I had it how like I would understand, it would be for me, you know? And I sent it to her, she's like, your information is good, but it wasn't like flow charting, it was like epidemiology, physiology, diagnosis, treatment, you know, like that. She was like, it needs to be more flow charting and having color or any pictures. Okay. Colors and.
I put color. I don't have a picture in my.
I put like 2 colors, 3 pictures. I put a picture of a thermometer, like the bird. Yeah, definitely like. We should. No, that's definitely. I don't think teacher would care. Yeah.
Teacher's like, what's going on? Oh, it's Spirit Week.
Yeah, I had it like.
Do you have a day?
Winter break. So you are you coming? We're so hard to like.
I wouldn't say really. Oh, yeah. Yeah.
I know some are, so they don't have to be there.
Oh, you do?
Yeah.
Like,
Oh, did I miss that?
Maybe.
Yeah. Oh, maybe you are coming tomorrow. How do I pull it up on her computer? I guess I need to download it on my phone. Which is awesome. Okay. Apparently that know that I had to do that.
Yeah, why? We're gonna extend it, talk about it. Come back. Okay. We feel lonely tomorrow, Monday. You're so funny. I could just do it. Like duck every time, get an umbrella out. Oh my God, we got it.
Is it flavored?
It's got a little bit.
Hit me up with some of that.
When I got
You brought your mug on a good day,
I
yeah.
don't think that much.
You get it anyway.
You have a gallon. I was like, what if she makes a gallon of coffee?
No, we're good all day.
All day?
Yeah. Because we have a mental health ATI cracker today.
That wasn't.
Too.
Hey, I forgot a reflex, a very important one. You said that. Who caught it? Who caught it? Oh, I didn't stop the pause. I didn't pause the recording. Oh well. Hey, so I forgot a reflex that we check on babies. It's called Babinski reflex. So if you take your thumb up the baby's foot, they will go like this with their toes. Okay? So anybody are we all here?
Yeah.
Everybody? 2, 4, 6,
Tyler's
8,
not here,
10,
but
12.
he'll be here.
Anyway, so he doesn't know what that is. 'Cause,
I'll show it to him.
but if you go like that up the baby's foot, their toes will go like this. So it's fun to do. It's kind of like, tickle the baby. All right. Okay. Needs care and feeding. Okay. Nursing care during the first 4 hours. So when the lady is in labor, we want to know these things, or whoever's caring for the baby is going to want to know these things if she can before the baby's born. It just kind of helps prepare you for what you might get, okay? How long was the labor and how hard was it? Okay, so if it was a very long, hard baby, we might have, a very long, hard birth, we might have a baby who is, exhausted. Maybe baby's a little short on oxygen. So we want to know those things. The status of the mother and the baby in labor. What were our heart tones in labor? The antepartum history. Did mom have any health problems or OB problems? What is her age? What was the due date? So we know how many weeks our baby is. Did she have any previous pregnancies and what were the outcomes? Do we know if this baby has any congenital anomalies? Gosh, that would be so great to know before baby is born. And is there any infections going on? Does mom have any infections that we need to know about? And were there any medications given during labor that may have side effects that I need to prepare for in my baby? So when baby's born, baby goes straight up to mom's chest. I think I changed that answer on that question. Chest or abdomen, like this area, okay? Babies go straight to this area right after delivery, okay? And we do the skin-to-skin thing, okay? So the studies are showing that moms and babes who are skin-to-skin, they both have physiological responses to skin-to-skin. Babies who are placed skin-to-skin transition quicker and with less incidence. In other words, they start breathing better. Their heart rates are better. Breastfeeding actually is better for babies and moms who were placed skin-to-skin, okay? And babies' temperatures and blood sugars. Yes?
Same with dad. I mean, obviously not for breastfeeding.
Well, right. Yeah. If baby is skin to skin with dad, that's just as good. Okay. Anyways, so we do that, and then we do our APGAR scores. Now, our APGAR scores have nothing to do with whether or not we need to resuscitate a baby. Okay. They're just an assessment, a screening of how well baby's doing in that point in time.
You do this on mom?
If baby is on mom, we can do this on mom. We can do almost everything on mom's chest. We can give meds, we can assess heart rates, we can take temperatures, we can listen to bowel sounds, we can do just about anything on mom's chest, okay? So anyways, we do APGAR scores at 1 and 5 minutes. I'm going to show you what APGAR scores are. So this is immediately after delivery. We'll weigh the baby, we'll do the measurements. The measurements are usually length and head circumference and chest circumference. We don't typically do an abdominal circumference. But if you had a baby with a known abdominal anomaly, okay, you do want to start doing abdominal circumferences, okay? But they're not typically part of the routine measurements. Just head circumference, length, and chest circumference. Now with head circumference, that's all great and fine and dandy, and you can just, oh my goodness, you pushed a 14-inch head through your vagina. Oh wow. But if baby had a traumatic delivery, okay, if they used forceps or a vacuum on this baby to get this baby out, you're going to want to know what that baseline head circumference is, because now you're going to do head circumferences every 4 to 6 hours for about 24 hours to see if we're getting any swelling in that head, okay? All right, so we'll do vital signs. Vital signs on babies are temperature, heart rate, and respiratory rate. We don't routinely do blood pressures. In NICU, they do routinely do blood pressures, but normal birth, normal babies will probably never get a blood pressure done while they're admitted in the hospital, okay? The one time where I would do blood pressures is if I heard a heart murmur, okay? So I would do blood pressures, I would do 4-point blood pressures. What's 4-point blood pressures? 1, 1, 1, 1, yes. I would do on all my extremities, okay? If I have a heart problem, I want to know that my blood pressures are, I think my systolics need to be within 10 millimeters of mercury, and my diastolics are 5 to 10. Maybe they're 10 too. I don't remember. But anyways, that's a NICU nurse's job. I would do blood pressures and I would call the NICU nurse. This is what I got. Anyways, we don't routinely do hematocrits. Some pediatricians want hematocrits done on all their babies at 4 hours of age, period. Whether there's risk factors for anemia or not, or polycythemia or not, okay? And the normal crits will be 43 to 63, okay? One facility I worked at, that pediatrician wanted hematocrits 40 to 70, okay? So just know your pediatrician's preferences, okay? But we don't routinely do crits. And then blood glucose. So we don't routinely do blood glucoses on every baby unless they fall in one of those parameters. Mother is diabetic in some way, shape, or form. Baby was preterm. Baby's large for gestational age, small for gestational age, IUGR, or baby has a temperature instability. Why does that affect glucose?
They'll burn more sugar to try to
Okay,
keep them warm.
right. We've done a resuscitation on baby. So I had to, right when baby was born, we had to bag the baby for 30 seconds. Therefore, baby is going to start getting blood sugars. What does that got to do with breathing? Any sort of stress on baby will cause them to use their blood sugars. Their blood sugar is what is fueling their metabolism. Okay? Metabolism is apparent in every process we do, from breathing to beating our heart. Okay? So if my baby has a problem breathing and beating their heart, they're going to work harder to try to do that. So therefore, they're going to use up their blood sugar stores. Okay? All right. So blood sugars 40 is the low. 96 it says is the high. I've gotten babies who are 108 on their blood sugar. I don't care. Really, I don't care about high blood sugars. Okay? I just want them above 40. Now, here's our APGAR scoring. So we look at 5 parameters. We look at the heart rate, the respiratory rate, the muscle tone, reflex response, and skin color. Okay? So you can see what the scores are there. If their heart rate is absent, they get a 0. If it's less than 100, they get a 1. If it's greater than 100, they get a 2. There's your respiratory parameters and your grading, your muscle tone. Are they really, kicking up a storm, or are they just laying there? Reflex response. So this is when I'm drying my baby off and stimulating my baby. Maybe I'm flicking my baby's feet. Is my baby just laying there taking it like a rag doll? Okay, that would be absent. No reflex response. No response to what I'm doing to it at all. It's just laying there. Okay, if my baby kind of, I don't like that, stop doing it. And that's all my baby does, she only gets a score of 1. Okay, but if my baby cusses me out laying there on the table, then my baby gets a 2. Okay, if she's screaming, if he or she is screaming, if they're fighting me, they get a 2. And so we add up those scores. Now, normal babies are anywhere between 8 and 10, and some pediatricians or people will tell you that if you're in a high elevation, your baby will never achieve a 10. And there have been times where I've been like, I can't not give this baby a 10. And the one parameter that they will get docked for is their skin color, okay? So most babies are born acrocyanotic. And there have been some babies where like, I can't, there's no, that's not acrocyanotic, like that's pink and red. I gotta give this baby a 10, okay? But anyways, there's some people say high elevations, babies can't get a 10. So we do this at 1 minute and 5 minutes. Now 8 to 10 is normal. 7 is normal as well. But if we get a score less than 7, we continue to do APGAR scorings every 5 minutes until we get a score above 7, or we hit 20 minutes. And then we're like, you know, these scores are stupid and we need to be doing real stuff for this baby, okay? So, that's the thing on APGAR score. We put the baby skin to skin. We do those vital signs I was telling you about. So immediately after birth, we do those vital signs every 30 minutes for 2 hours, okay? And then we'll change our parameters. If we're doing vital signs every 30 minutes for 2 hours and our vital signs are abnormal, I'm going to continue to do them every 30 minutes. Or I may even start doing them every 15, depending on what the problem is. But typically, every 30 minutes for 2 hours, and then we'll go every hour for 2 hours, and then baby will be Q4 for 24 hours, and then Q8. But immediately after delivery, it's every 30 minutes for 2 hours. We're assessing the respiratory rate. Normal respiratory rate is 40 to 60. We'll be listening to lung sounds, and we'll be evaluating whether we have grunting, nasal flaring, or retractions. Okay? Grunting is that cute little sound that parents will say, oh, listen, my baby's singing. And they're going, and that sounds super sweet, doesn't it? But what that means is baby's trying to create pressure in their lungs, okay, so that they can get the fluid out and get the oxygen in. So it means something bad, although it sounds very precious. Nasal flaring, because babies are nose breathers, so when they're having trouble oxygenating, those nares will just flare out every time they take a breath, okay? And retractions are like, so intercostal, substernal, clavicular, like the skin between the lungs, below the sternum, up above the clavicle. I can't do it. They're sucking it in because they're sucking so hard to get air. They're pulling that skin in. Those are called retractions, okay? Now, if I had a baby, so your lung sounds will typically sound horrible right after delivery because they're still trying to get rid of that fluid in their lungs. So you can be hearing crackles on your baby's lungs for maybe a couple hours even. But that's okay. We're not going to do anything about it because our respiratory rate is normal and we're not doing any of this grunting, flaring, retraction business, okay? And I'm pink, okay? But if I wasn't pink, or if I was grunting, flaring, or retracting, then I'm going to put an oxygen saturation on my baby, okay? I'm going to put a preductal. So what's preductal? Does anybody know? What does ductal mean? It's a duct. It is the ductus arteriosus that connects to the aorta, okay? So where that duct connected to the aorta, preductal means it's the part of the body that's being supplied with oxygenated blood before that duct on the aorta. So that's the right hand, okay? And it's the right ear, okay? It's this part of the body. When I say postductal, I'm asking about what part of the body is supplied with oxygenated blood after that duct, okay? And so that would be everything else, okay? So we want to know preductal, and I would put an oxygen saturation on my baby. If my baby's oxygen saturations were normal, and my baby was grunting, flaring, and retracting, would I do something for this baby?
Yes,
What?
and you would put surfactant in its lungs.
No. I would monitor this baby. I've got a normal respiratory rate, I've got normal oxygenation, but I'm grunting.
Oh.
Yes.
Would you check a blood sugar?
I would probably eventually check a blood sugar, but pretty soon, but not immediately. So, but what I'm getting at is if you have a normal respiratory rate and you have normal oxygenation, if your baby's grunting and doing this business here, then we know our baby is working a little bit to oxygenate, but maybe this is a transitory thing, okay, so I'm just going to monitor my baby. If my baby's oxygen saturations were not normal, I would be giving my baby oxygen, okay? If my respiratory rate was abnormal, if my respiratory rate was really fast, what is that telling me my baby's trying to do? If my baby's breathing at 80 breaths per minute, why is she breathing so fast? What's the first thing that comes to your head? Why do you breathe fast? You don't have enough oxygen. You're breathing fast so that you can breathe in oxygen, okay? So if my baby's breathing fast and then she's telling me, I'm trying to get oxygen, I'm having a problem here. If she's not grunting and flaring and retracting, what do I need to do? If she's just breathing fast and she's not grunting, retracting, or flaring, what do I need to do? What is my baby's oxygen level? If she's just breathing fast and not grunting, flaring, or retracting, what should I do? Get an oxygen sat on, okay? Okay, see what my oxygenation is. If my baby's oxygenating, if she has a normal oxygen saturation, do I give her supplemental oxygen? No. Okay, I watch her, I monitor her more frequently than every 30 minutes, right? Okay, I keep her on the oxygen saturation monitor. Maybe she's breathing fast because she needs to get oxygen in, but she still has a little bit of fluid in her lungs, so it's hard to get past that fluid, so she has to, work a little harder, okay? So I'm waiting for my baby to transition, okay? That's why we monitor them so frequently, is because we're making sure that they transition normally. And if they're not transitioning, then I need to watch her more frequently and wait for her to transition, okay? If she doesn't transition, if my baby's breathing at 80 breaths per minute, okay, she's going to get tired. She's going to crump, okay? And then I'm going to intervene how I need to intervene, okay? But she can have some abnormal assessment parameters, but if she's oxygenating, if she has normal oxygenation saturations, then there's really nothing I can do, okay, except watch her and wait for her to either get over it or declare herself in need, okay? Now, so that's respiratory. Now I look at her heart rate. Is her heart rate normal, okay? 110 to 160, okay? If it's abnormal, I gotta ask myself all those questions again. If she has a very high heart rate, why would a baby have a very high heart rate? Why would her heart rate be 180 beats per minute? Huh? Stress. But what is she doing? Why is her heart beating very fast? What is that fast heart rate doing? Oxygen. Oxygen. Okay? She's beating fast because she needs oxygen. Yeah, she's in stress or whatever. She doesn't feel good. But she's beating fast because she needs oxygen. Okay? If her heart rate is fast and her respiratory status is absolutely normal, and my baby's heart rate is fast, she's telling me I'm trying to oxygenate, I'm trying to get oxygen out there, so I'm beating really fast, what do I need to do?
Temperature.
Check an O2 sat. I need to see if she's being successful. If she's being successful and she has normal oxygenation status, what do I do now? Monitor her. Monitor her. Yes.
What's normal O2 sats? Is it still like
It's
upper
still,
90s?
yeah, it's still 90 to 100 if we're not supplying oxygen. Okay? And some NICU people are comfortable with 88, but I'm not a NICU people. I'm a labor nurse. I want that oxygen above 90, okay? And then if my heart rate is low, what's baby telling me if her heart rate is below 110? What does the heart need to beat? It needs oxygen and it needs a blood supply. So one of those things is messed up. Okay? So I'm going to jump in and intervene. Okay? When it comes to babies, 99% of the time it's an oxygen issue. Okay? 99%. And actually, these probably aren't current, this probably isn't current data, but 10% of babies, term babies, 10% of them need some sort of resuscitation after delivery, okay? And resuscitation could just be bag mask, okay? 10% of those babies need some sort of resuscitation. 1% of those 10% need a full chest compressions, bag mask, NICU admission. Okay, so I don't know what that number is, but it's very tiny. The majority of the time, it's an oxygen issue. Okay? All right. And then murmurs. Do we hear any murmurs? Okay? We may be able to hear a murmur because what we're hearing, hopefully, is we're hearing blood rush through those fetal ducts. The fetal ducts, the arterial ductal and the foraminal valley, we may hear blood rushing through those because they haven't just closed yet. I mean, it's not like a door being slammed as soon as that cord is getting cut. Sometimes it takes a little bit, okay? So hopefully, if we do hear a murmur, it's because those ducts haven't closed yet, and that here in a few hours they will close. But after a few hours, and 12 hours, and 24 hours, if we're still hearing a murmur, then we're doing 4-point blood pressures, we're doing pre and post oxygen saturation tests, and then we're calling the physician and saying, this is the deal, and we may end up be doing an echo on a baby in the hospital. Okay. Oh, and by the way, pre and post ductal saturations, we do those on every baby's at 24 hours of age. That is our congenital cardiac heart defect screening. Okay, so at 24 hours, all babies will get a pre and post ductal oxygen saturation. If they are above 95 on that screening, both the pre and post, then baby passes. Okay? If they are within 3 percentage points. So a baby could be 95 on their post-ductal and a 99 on their pre-ductal. That's not 3%, that's more than 3%. Baby just failed. Even though baby was over 95, they've got to be within 3% of each other. Okay? So they can be over 95, but if they're not within 3%, they fail. And then you call a physician, and then they'll probably order an echo. Okay? But if they're not over 95, if one or both of them are not over 95, then baby failed, and baby, you'll call physician, and baby will get an echo. And may just be perfectly fine. There may not be heart disease at all, because remember, this is a screening. And what does a screening tell us? Is that it's definitive? No. It's just a screening, maybe, maybe not. Okay? So, there we go. Okay, skin color, we're always looking at our skin color. Acrocyanosis can be normal, but we want our baby to always be centrally pink. Where is centrally pink at?
Head and thorax.
Mucous membranes, right here. Okay? Lips, mucous membranes. Our temperatures, there's our ranges. If baby has a temperature problem, it's going to be a hypothermia, not a hyperthermia. In other words, their temperature is going to be low, not high. Okay? Because babies' metabolisms aren't mature enough to generate heat like our metabolism is. So if they're struggling, their metabolism is not going to be keeping up. Okay? And it couldn't anyway. It couldn't generate the heat, and babies' temperatures will drop. Okay? We're looking at their tone. So, are they just laying there flaccid, or are they nice and flexed? Now, if we have a term baby, we anticipate our term baby to be flexed. If our term baby is flaccid, then we have an issue. We have an oxygenation issue, or blood volume, blood pump issue. Okay? We expect our preterms to be flaccid or extended, okay, or poor tone, but not our term baby. So we'll get our length, our weight, our length, our head and chest circumference. Now it's very important that we get our weight pretty quickly after delivery, within an hour, hopefully. But sometimes mom doesn't give that baby up in that hour, so you get it as soon as you can. We want to know the weight so that we can plot the weight on that little scale to see if our baby's AGA, SGA, or LGA, okay? Because if our baby is one of those SGAs or LGAs, then we need to start doing blood sugars. All right, so in the delivery room, sometime, baby will get vitamin K and erythromycin ointment. If parents are agreeable. If they say no, they don't get it. Babies don't get it, okay? Vitamin K helps prevent bleeding. It's part of the blood clotting cascade. Babies' guts are sterile, so they have not created their own. And so we give them vitamin K. Erythromycin ointment for the eyes. We put those in the eyes to prevent infection. So a lot of times most parents are like, yeah, go ahead. A lot of parents will skip the erythromycin ointment, say no, 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 no. And then they'll say nope to the vitamin K, and then we call we do some education with mom on the importance of vitamin K and how your baby just came slamming through a bony birth canal and could have some issues in their head and might bleed. And if they bleed in their head, they will be very, 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 very sick. Okay, so can we please give your baby vitamin K? And they will say no, so we'll tell the pediatrician. The pediatrician will come in and say the same thing. And majority of the time, then the parents are like, okay, give it. Just get off my back. But vitamin K is quite important. If babies have bleeding issues in the brain, that is very, very bad. So when we give vitamin K and or hepatitis B vaccination, we give it in the vastus lateralis of the baby. What size needle do we give? What gauge and what length?
25 gauge, 5/8.
25 gauge, 5/8. Vastus lateralis. So this is how I find out where that muscle is. I place my hand, or imagine my hand, on the top of the baby's thigh, and I place my hand on the side of the baby's thigh, and I go for that corner. About midway in the thigh. Okay? Do we aspirate? Nope. And here's us putting erythromycin ointment in the eye.
Is there any risk factors for that?
Erythromycin ointment? Well, I'm sure there's probably,
Chemical irritation.
yeah, I mean, baby could possibly, for some reason, develop an allergy, but that would be pretty rare because babies can't really respond that way yet. We could poke the eyeball and cause trauma, but other than that, not so much. They just don't want it. I just don't want it. I don't have any cooties, so my baby's not going to get an eye infection, okay? So that's what they say.
So if you didn't have a vaginal birth, why would you need to do that? Isn't that kind of to protect against the...
So, right, but some of the infection could be not necessarily genital. It could ascend and or it could be systemic. So that's how. Okay. So we do head to toe assessments every shift on babies. We check out the head, like I said. We look at the eyes for drainage, ears, nose, is everything intact? Then we just move down. So then I always palpate my clavicles. My baby could have had a clavicle injury, so I palpate my clavicles. Then I move down and I lift my arms and make sure my baby's arms are moving freely, okay? If I lift the arms and this one just drops down like this, I might have some sort of injury here from birth, okay? So I'll check my arms, and then I come down and I check my legs, okay? I do a capillary feel on my knees, okay? And I do one on my forehead. And then I listen to lungs, I listen to bowel sounds, I look at my abdomen, I make sure the umbilical cord looks fine. I might feel around the baby's belly a little bit to see if I can feel any lumps, but I don't palpate to feel organs. Okay, but I just feel around, make sure I don't have any hernias or any cysts or any funky looking feeling things. I open the diaper, I look at my genitalia, I roll baby over, I look at my anus, and I look at my spine, and I look for a tuft, okay? I do my reflexes, and then I'm done with my head-to-toe assessment. Voids and stools, so we like babies to void and stool within the first 24 hours. And most of the time we get that. If babies don't void or stool within 24 hours, and we know that they've had adequate feedings, then we might be doing some ultrasounds and check to see if everything's okay with that. Check reflexes, my skin. One thing we do to make sure our baby's temps stay good is skin to skin. If we could do skin to skin continuously for 24 hours, we would do it. If mom is willing to do that, if she's not, we check with dads. And if they're not willing to do that, then we put hats on babies and wrap them in blankets. We don't typically dress babies in clothes, okay? If we do have a temp issue, we'll put babies under the radiant warmer. The radiant warmer is, you may have seen if you went on the tour, it's this bank thing that's over like crib type situation, and it puts heat down on the babies. But we need to connect baby with a sensor. We put a little sensor over the liver, put a little patch on there, and then plug that into that warmer. That sensor will tell us what the baby's temperature is, and we adjust our warmer to what temperature we want our baby, and it'll keep our baby at that temperature. So we won't be cooking our baby with blasting the heat, and we won't be under regulating our baby. So if we had to do a radiant warmer, that's what we do. Cord care is really no care. Back in the day, doctors liked alcohol on the cord. Some facilities do this triple dye stuff, this black inky looking stuff or purple inky looking stuff to help dry up the cord. But studies are showing, quit doing stuff to people, let them live their own life, let the cord dry up on its own, natural process, it's fine, leave it alone. So that's what we do. But we do assess it to make sure that it is going okay. And then safety, big issue. So we put ID bands on baby, we put security bands on baby, ID bands, so baby gets their ID band and mom and dad get one, that's the exact duplicate. And that's how we know who belongs to who. It also tells us that if anybody is in possession of a baby, if they don't have a band on, they shouldn't be holding that baby, or they shouldn't be having that baby, okay? So you've got visitors in the room, everybody's holding the baby, that's fine. But if I saw someone in a hallway with a baby and they didn't have a band on, I'd probably go say, hey, what's up? What you doing? Security bands, they're connected to the alarm system of the unit. So if baby tries to get out any of the unit, those alarms will go off and the whole place will be locked down. You couldn't even badge through a door. If a baby alarm is going off, you can't even badge through the door, okay? The other thing is if the band comes off the baby, the alarm will go off. We instruct our patients that if you want to leave the room, your baby has to be in the crib. You can't carry your baby in the hallway, in the unit. Has to be in the crib. But you can take the baby out in the unit and walk around, but the baby can't leave the unit. And then, of course, we're going to do all of our infection control, our infection prevention practices. Questions?
So wait, the baby has to stay in the room, or you can take the baby out?
You can take the baby out in the unit,
Okay.
okay? But the baby has to be in the crib.
Oh, it has to be in the crib, out in the unit?
Yeah.
Gotcha.
So people have to push babies around in the crib.
Okay.
All right. We used to do circumcisions in the OB unit after babies were born. And they stopped doing this because it's a physician reimbursement issue. So the physicians will get more reimbursement if they do these in the office.
Can you ask them to do it then?
Uh-huh. Mhm. There is one physician at Community who does circumcisions in the hospital. Okay? Anyway, circumcision is a procedure where they cut off the foreskin of the penis. People do this for lots of reasons. It could be a religious requirement or part of their religious practice to circumcise their babies. People can want it done because dad was circumcised, so they want their baby circumcised. Or people can want it done because all the boys in the school are circumcised, so they don't want their son to be the only one not circumcised. That could be a reason. And it is easier to care for. I mean, straight up, it's just easier to care for than an uncircumcised penis. Not that it's difficult to care for, but it's easier. And the other reason is it can prevent, so future circumcisions, depending on how old you are a big major surgical procedure where you'll need anesthesia, and the risk for infection and increased pain is more significant than when you've done it at a newborn age where you can't say ouch. Okay? So anyways, that could be a reason. I have taken care of people in the hospital who have had children that are 11, 12, whatever years old that have had a medical necessity to have a circumcision for whatever reason. Okay, trauma, infection, and I've definitely seen my share of 80-year-old men, either in a nursing home or in a hospital, who did not get proper care and ended up with adhesions, wasn't able to void, or infection, and needed a circumcision at 80 years old. That's negligence. That's not, that's negligence, okay? Yeah, I have seen that, okay? Matter of fact, the worst case, and I thought if I ever saw a physician strike healthcare workers, it was going to be this time, and I was scared. Because I'm the one who found this and told the physician, and I'm sure he wasn't mad at me, but man, he was furious. He had, I don't know how old the patient was, it was an old guy who had a TURP, and so a TURP is a transurethral, it's some craziness. He had this humongous Foley catheter in that was an irrigation and a drainage catheter at the same time. And no one was doing catheter care on this old guy who was not circumcised. And the foreskin adhered to the catheter.
Oh my God.
Okay? And I couldn't get it undone. And I had to call the surgeon. And he came in and assessed it, and he couldn't get it undone. And he had to take this man into surgery and perform a circumcision to get that off there. And he was flippin' livid. And and justifiably so. People did not take care of that. Yes?
All you have to do to take care of that is just draw the foreskin back and clean
Clean
it.
it and put it back where you found it.
That is awful. Oh my God.
You know, I'm kind of glad that I'm teaching the foundations class because hygiene, skincare, and nutrition don't seem to be important when someone's in there with chest pain, right? Or someone's in there with knee surgery, or someone's in there with cancer, okay? Those are the basic, that's the foundation your house is built on, okay? And it'll crumble right there in your hospital room, okay? So do these little tiny friggin' things. Okay, I'm sorry. That's my pet peeve. Okay, contraindications to getting a circumcision. Prematurity, okay, or weight. So if the child is not over, I can't remember if it's 4 pounds or 5 pounds, even if they weren't premature, they're not getting a circumcision. They have to be over 4 or 5 pounds. They have a bleeding problem, okay, or they have a defect like hypospatus or epispatus. What's that? The urethral opening is not at the tip of the penis. If it's epispatus, it's on the lateral or top surface of the penis. If it's hypospatus, it's on the bottom. And it could be anywhere in there. And if it isn't a severe one, so maybe it's just right off the edge of the penis, right below, or maybe it's just right above. One of the things that they're going to do is they're going to use the foreskin to repair that. So we can't cut that foreskin off because they might want to use it. Anyways, you need a consent. And then what most pediatricians do is they inject lidocaine, okay, into the base of the mons, right below, right before the penis. Okay, they'll inject on the top surface. Okay, they can't inject on the bottom surface. Okay, they can inject on the top surface, and that numbs the top of the penis and a little bit on the sides, but it doesn't numb this part right here, this bottom part. Okay, and then we give Sweeties. Sweeties is a high fructose solution that kind of attaches itself to the pain receptors, kind of like morphine does. I mean, it doesn't act like morphine, but it puts them in a euphoric state. Go ahead, cut that off, I don't care, okay? All right, so we give the local, we give the Sweeties, and then we strap the baby down on this plastic board that has a little mold of a baby body, and we strap the baby down. Okay, usually what we do is we take a blanket on the top part of the torso part, we put the arms down and we wrap the arms in, okay, tight so they don't get out. And then we put actually straps across the legs, okay, to keep the legs still. And then they'll do one of these type of Gomcos, okay, or I'm sorry, circumcisions. And I'll tell you about them. I don't know anything about the Mogan. I've never used the Mogan, but I've used the other two. And then we're going to educate our patients on how to care for their circumcision, okay? So this is your Gomco. And so what they do is, actually what they do is they put a little clamp right here on the tip of this foreskin, okay? And then they take this little proby device and they come in and they release any adhesions or stickiness. They make sure they can go all around the penis, okay? And then they take this little hat and they sit it right down over the penis and they're pulling this foreskin up over that hat. So the penis is in there and then the foreskin is coming up over. Yes?
That's different than any Gomco. I've used this metal.
So usually they're metal. But
They're a clamp.
yeah, you'll see it. Okay. Usually those little hoods are metal. Okay. And then they go in this barbaric looking torture device. Okay. So there's a hole in this plate right here, and they stick all this contraption up through it, and then they hook this part. They hook it down under these little levers, and then they come over here and put it down on this screw, and then they screw this thing in. And as they're screwing, it's kind of pulling this and making this all taut and straight and pulled and tight. Okay? And what they're supposed to do is wait 5 minutes. Tea time, tea time. Okay, 5 minutes is up. They cut the foreskin around there. Okay? That's the last picture I had. And so you have this foreskin that's cut. Okay, so this is gone. This is left. And then so we have this penis, the head of the penis sticking up out of there. And it's like you just broke open a blister. That skin is oozy, owie, sorry. So our instructions for care is take petroleum jelly and just slap it on all around that penis head, okay? And the reason is so that when you put the diaper on and that wet, moist, fresh skin does not dry to the diaper, and then you pull the diaper off to change the wet, poopy diaper and rip that precious skin, okay? That's why you do the petroleum jelly. You do no antibiotic ointment, you do nothing else. You just slather that with petroleum jelly until that skin has completely granulated and healed. And then you can stop doing it. The other thing is, these babies need to pee within 6 hours. Okay? Because we just messed with the pee hose, and if we've hurt the pee hose somehow, then we need to know and evaluate the damage. Okay? These things bleed okay? And that's the reason why they need to hold that on there for 5 minutes. They need to kind of, not cauterize, but they need to kind of tamponade off those vessels so they don't bleed. And so parents will see a little bit of blood on the diaper probably every time until that has completely healed. But what we don't want to see is blood just kind of continuing to trickle out and trickle out. Now, if your physician does have a tea time, then the nurse is probably standing there before she takes the baby back to the parents, holding pressure on that penis because it's bleeding like a stuck pig. Okay? So, physician, you've got 2 more minutes. Hang on. Wait. Okay, now there you go. The other thing, my personal, like if I was to have a circumcision, I would not want this one because this is my deal. If they did not hold good pressure up there, and even if they did, they only held it for 5 minutes, that skin can drop like a sock and heal crooked, gangly, and not straight. Okay, so that's why that would not be my preference. This would be my preference. This is called a Plastibell. Okay, so it's this little cap thing. Okay. And they do the same thing to the foreskin. They grab it with a clamp, they go in with that little pokey deal, and they loosen it all up around, okay? So they've loosened it all up around, and then they slide this little hat in, okay? They pull the foreskin taut, and then they take this string and they tie it around this little edge here. Okay, and it kind of holds that string in place. It's kind of like a little trough for the string. And then they tie that string as tight as they can. They trim the string. They trim the skin all around. So all you have is this device with this little string around it. Okay? Then they break off this part. Just breaks right off. So then all you have is this part, okay, this little cap right over the top. There's a hole in the cap so they can pee out the deal. Now, the good thing about these things is they bleed very little because of this string. It stays on there, okay? So if you would put a string around your finger and you tied it tight and you kept it on there for a week, that finger would just go away, okay? So all this, the rest of this skin, like they trimmed it up, but there's just a little bit of skin like that. Shrivels up and dies, it adheres, when that heals, then the cap falls off, this old dead skin falls off, the string falls off, it's completely healed, it looks beautiful. Okay? Very little bleeding, very little problems. What the parents need to do with this circumcision is absolutely nothing. Don't do anything to this. Don't put ointment on it, don't put Vaseline on it. If you do, you will loosen up that mechanism there and it'll fall off prematurely. Okay? Don't do anything. Just let it be. And this is what they might see. This is that plastic cap with the thing broke off, the string, you can see the string tied there. Baby can pee out that just fine. You might see some little spots of blood on there, but that's okay. But we don't want to see like bleeding, okay? All right, and this is the Gomco. I should have moved this up. So this is the Gomco. You can almost see in this picture, well, they've got it all gooped up with Vaseline, but this, the skin is already not straight. So, perfect. It's wonderful. Okay. All right, now this is the Mogan clamp. I've never seen it used. It's still barbaric. We're not even going to talk about it. All right. So, the whole time the patient's in the hospital, from the time they come into labor, teaching starts. Okay, we identify what their needs are and we start teaching because we've got so much to cover with these people. So we teach them about newborn care, skin care, bathing, safety, safe sleep, feeding, signs and symptoms to be concerned about, what to report to the doctor, all those kind of things. We teach the same thing of postpartum care. How do you take care of, did you have a vaginal delivery? How do you take care of your perineum? If you had a C-section, how do you take care of your incision? What kind of bleeding are you supposed to be expecting? What signs and symptoms are important to report? Big thing with postpartum care is pain. Whether you've had a vaginal delivery or a C-section delivery, we should be sending you home with medication that helps your pain, or at least decreases it from a 10 to a 2, okay? But if you've been taking pain medicine that has been taking care of your pain, and now all of a sudden your pain is always a 6, pain medicine is not helping, then something's wrong. So we need to know about that, okay? So infection, car seat safety, we can tell people about their car seat, we can instruct them, but we can't touch the car seat. I can't even touch the car seat. If I touch the car seat and they put it in the car wrong and they get in a wreck and their baby is injured, they can say, oh, but that nurse, okay? So unless I'm a certified car seat technician, I can't touch the car seat, okay? We let them know about community support groups for whatever their needs are. Now, before discharge, these are all the things that baby does. So I said baby gets that CCHD testing, the preductal and postductal. These are what we call 24-hour cares, okay? We do this 24 hours for every baby. We do a transcutaneous bilirubin, okay? It's a little device we put on the sternum that reads what their bilirubin level is in their skin, okay? It's a screening, so if it's elevated, then we need to do a serum test. We do the metabolic screening or PKU test. It's the test where we do the 5 drops of blood on the piece of paper and then send that to the state, and they test for all these disorders. We do a hearing screen. We do the heart preductal postductal test, and we give the hepatitis B if they want it. For God's sakes, I thought I was going to make it. I'm going to stop here and record the rest. I want you guys to watch a video. First of all, let me do this because Tyler can go. This is on Moodle.